Obesity. Why we need to confront this pandemic. When the COVID pandemic hit, it revealed an underlying pandemic already in existence and growing: obesity. Why call it a pandemic? Because this epidemic, recognized in the U.S. for 2 decades, spread worldwide to the point where in 2013 the World Health Organization called for zero increase in the prevalence of overweight among children and in the prevalence of obesity among adults. From 1990 through 2015, there was a relative increase of 28.3% in the global rate of death related to high BMI. Why was that pandemic allowed to spread globally, and why are the alarms not so loud? Primarily due to a set of excuses and defenses we will discuss, including the global spread of a food industry bent on supplying inexpensive, high-caloric foods, a misinterpretation of political correctness, in other words, fat shaming, and the demonstrated difficulty with changing individuals' lifestyles, and now a sense of a new normal. And in fact, when 39.5% of the adult population in the U.S. and 18.5% of those between the ages of 2 and 19 are obese, it becomes a new normal. It becomes normal if you see 3 out of 4 adults overweight and 1 in 3 people walking around obese. And when you live in a family of obese individuals, it's an implicit agreement that this is normal for your family. So what is our role as health professionals? Well, like the preventive profession we aspire to be, it's about knowing what obesity predisposes your patients to, what it increases the likelihood of, and more importantly, it's about providing management, or when not possible, resources for accomplishing sustained weight reduction. But first, there has to be a conversation with that patient. It's the conversation we avoid. Why? Because it's uncomfortable. Ironically, because we care for our patients, we don't want to embarrass them or make them feel judged. But what we as health professionals can't use as our excuse is that we're fat shaming. Let's be clear, making fun of or demeaning someone for their weight is inexcusable. But so is not warning someone about the risks of being overweight when we are their trusted health advisor. And they are entirely different in approach. Shaming someone into change never works anyway, but showing concern and providing evidence of benefit does, as we will see. This is not about judgment. Obesity is a complex phenomenon that is not only related to obvious lifestyle missteps, but also to the defense mechanisms that provide a barrier to change. And this may start with accusations that you're accusing them of not being a good person, not intelligent, lazy, inferior. But how is it that telling someone that they have a disorder is synonymous with condemning them as a person? Clearly, this is not logical. Would you not tell a patient if they were hypertensive and needed to manage their hypertension, or from their lab diabetic and they need to manage that? And as we'll see, these are 2 associated conditions with obesity. And it might be helpful to remind yourself and the obese patient that there's no evidence of a relationship of obesity to laziness, lack of intelligence, lack of value to family or society, and that although this is a physically manifested problem, it has a burdensome psychological impact that ironically may prevent change. The focus on obesity is cosmetic, but cosmetic implies something superficial. Obesity is a much deeper health disorder, affecting literally every aspect of well-being. To educate our patients, we need to first be educated. If you've ever been overweight, and I was as a child, you look for the evidence that overweight is not necessarily bad for you. It's a normal variation. And you may be correct, dependent on age, gender, and other contexts, but we're not discussing overweight. We're discussing obesity. What's the difference? It's easy to determine. Here's an online calculator anyone can use, and although it's calculated in unfamiliar terms such as kilograms and meters, the category you fall in is pretty clear. It's a calculation of your body mass index, and yes, certain factors may affect this, such as having a large percentage of muscle, which gives a skewed interpretation, but on average, it's a great gauge and easy to utilize and compare. We see the categories of being overweight from 25 to 29.9 and obesity as a BMI greater than 30. High BMI is a risk factor for a number of chronic diseases, including cardiovascular disease, diabetes, chronic kidney disease, many cancers, and many musculoskeletal disorders. From the CDC, we see that the trends of obesity and severe obesity among adults is increasing. From 2000 to 2018, the prevalence of obesity increased from 30.5% to 42.4%, and the prevalence of severe obesity basically doubled from 4.7 to 9.2%. And this is not evenly distributed. It's higher in blacks and Hispanics than whites, and far less in the Asian population. And look at the population percentage who are overweight, around 71%, and for those who are obese, on average, 39%. And look at the growing trend in children, where now approximately 20% of those from ages 6 to 19 years are obese. What is alarming is that we can see obesity and extreme obesity are on the rise in the U.S. Note there was a small decrease a few years ago, but that's been surpassed by gains in recent years. Note also in the U.S., the distribution is not equal. 7 states have 35% of their populations meeting the BMI threshold for obesity. These include Arkansas, Iowa, Louisiana, Mississippi, Oklahoma, and West Virginia, mainly southern states. And again, for those who simply believe this is a variant of normal, no state had an adult obesity rate higher than 15% in 1985, and no state above 20% in 2000. In quick summary, then, obesity is more prevalent in non-white, black, and Hispanics, women as compared to men, those who live in rural areas, and those who live in poverty. The good news is it's less prevalent in those with a college education and those with a high income. Let's start with one of the largest studies on the topic ever published. In 2017 in the New England Journal of Medicine, health effects of overweight and obesity in 195 countries over 25 years. What was important about this study was their focus was primarily on the fact that previous studies did not consider the relationship of high BMI with broader socioeconomic development and did not assess the effect of epidemiological and demographic transition on disease burden. So what did they find? By closely following age groups based on 5-year increments, correcting for self-reported errors where individuals tend to overestimate their height and underestimate their weight, and by comparing BMI to socioeconomic variance and geographic locations in 195 countries, they concluded that excess body weight accounted for about 4 million deaths over 25 years, and that nearly 70% of the deaths that were related to high BMI were due to cardiovascular disease. They found in a recent pooled cohort analysis involving 1.8 million participants that nearly half the excess risk of ischemic heart disease and more than 75% of the excess risk for stroke was related to high BMI. This was through a combination of high blood pressure, high cholesterol, and high fasting plasma glucose. And most concerning is that this systematic evaluation of prospective observational studies showed sufficient evidence supporting a causal relationship between high BMI and cancers of the esophagus, colon and rectum, liver, gallbladder, biliary tract, pancreas, breast, uterus, ovary, kidney, thyroid, and also leukemia. Let's cover some salient risks with obesity, certainly as it relates to chiropractic, but to well-being in general. These will include low back pain, hypertension, diabetes, cognitive function and dementia, and immune function and its relationship to COVID-19. Let's start with low back pain. In this systematic review, obesity as a risk factor for low back pain, they found a statistical significant association between overweight and the incidence of low back pain, and even higher association between obesity and the incidence of low back pain. In fact, an increase of 36%. This increased BMI was associated with an increased incidence of low back pain in both men and women. Now, previous studies had been inconclusive regarding whether being overweight was related, and some studies suggested that women were not as affected as men. These findings dispute those previous beliefs. The results of their subgroup analysis demonstrated a stronger association between BMI and low back pain in the occupational population than in the general population, and most of these were in fact healthcare workers and industry workers. Let's move on to hypertension. The assumptions were that hypertension was related to metabolic influences. However, this study, Renal Consequences of Obesity, found that the increased risk might be due to increased visceral fat that compresses the kidneys, increasing intrarenal pressure and tubular reabsorption of sodium, leading to hypertension. And in fact, losing about 9 pounds decreases systolic blood pressure by about 4.5 millimeters of pressure and diastolic by 3.2. And now to cancer. In this study, Body Fatness and Cancer, a viewpoint of the International Agency for Research on Cancer Working Group, they found that 75% of people surveyed were unaware that obesity increased risk for cancers. Now, obese women have over twice the estrogen or estradiol levels of non-obese women, and adipose tissue is the principal site of estrogen production after menopause. As mentioned previously, the cancers that are at high risk are esophageal, gastric, colorectal, liver, gallbladder, pancreas, breast, uterus, ovary, kidney, meningioma, thyroid, and multiple myeloma. When people lose weight, their cancer risk goes down significantly. With a loss of 40 pounds, there's a decreased occurrence of cancer by 33%. And now to diabetes. What's the single most significant risk factor for type 2 diabetes? Not surprisingly, obesity. Your risk increases dramatically with a BMI greater than 35. For females, 95 times, and for males, 42 times. The risk of death is twice that of people of similar ages for those with diabetes compared to those without. 68% of adult patients with diabetes have hypertension. It's the leading cause of blindness in the U.S. for individuals between the ages of 20 to 74, and it's a leading cause of fatigue, impotence, infertility, and gallstones. Diabetes is the leading cause of end-stage renal disease in the U.S., leading to an alarming increase in both kidney dialysis and 25 to 30% of patients receiving some form of renal replacement therapy. Diabetes is also a major cause of gangrene of the feet and also a leading non-traumatic cause of the need for amputation of the lower extremity. And remember that smoking increases your risk. And for us, it's important to remember that diabetes is the most common cause of neuropathy, with 70 to 80% of patients with type 2 diabetes affected. Let's move to dementia. In this study, Midlife Obesity and Dementia, Meta-Analysis and Adjusted Forecast of Dementia Prevalence in the United States and China, published in 2013, they compared normal weight to midlife obesity and found that it increases the risk of dementia later in life by as much as 91%. They also concluded that if obesity is included in forecast models, the prevalence of dementia is estimated to be 7.1 million in 2030 and 11.3 million in 2050. As we see in this study, there are structural brain differences and cognitive functioning declines related to body mass index. So cognitive deficit is not from distraction, although individuals on average think about their weight 5 times per hour. These are structural changes in the brain in the left orbital frontal region. Obesity appears to accelerate aging of white matter and has been found in children as microstructural changes. Poor executive function was assumed to be due to associated factors such as hypertension. However, this large meta-analysis found changes present in large samples of young individuals. One proposed mechanism here is based on inflammation and oxidative stress, because these have been observed as decreases found with weight loss and increases in serum adiponectin. Adiponectin is a benign adipokine that sensitizes the insulin receptor signaling pathway and suppresses inflammation. It's been shown to be inversely correlated with adipose tissue dysfunction, and may enhance the risk of Alzheimer's disease because a range of neuroprotective adiponectin mechanisms is related to Alzheimer's disease pathology alleviation. And now on to immune function. In this time of COVID, there's a triple threat for the obese: a higher risk of infection, a higher risk for mortality, and a potential decreased effectiveness of vaccines. Why? Let's look at the relationship between adipose tissue and immune function. In this publication targeting the adipose tissue in COVID-19, they found that a study at the UK Intensive Care National Audit and Research Centre indicated that 2/3 of people who have developed serious or fatal COVID-19 related complications had overweight or obesity. Quote, the overexpression of inflammatory adipokines from visceral fat depots can affect the immune response, impair chemotaxis and macrophage differentiation. The imbalance between anti- and pro-inflammatory adipokine secretion from thoracic visceral fat depots can also play a role in the cytokine storm described in patients with severe SARS-CoV-2. Interestingly, adiponectin was reported to predict mortality in critically ill patients upon admission to the intensive care unit. The innate inflammatory response of the visceral fat depots can cause an upregulation and higher release of inflammatory cytokines such as interleukin-6. And finally, there are a number of studies that suggest that obesity has an effect on the immune system that leads to a decreased responsiveness to vaccines and therefore a higher risk for infection. This is particularly concerning given the initial predisposition to infection, a 1-2 knockout punch. So what's next? Well, in our next review, we will discuss some of the underlying issues regarding the causes of obesity and some of the evidence-based approaches that can be effective in keeping weight loss reduction sustained. Stay tuned.